Hi, how is it going? Happy Sunday. Hi, Chelsea. I'm going to add you in just a second. Let me figure this out. Hi, Ashley. You already know the answers to some of these questions. Okay, I am adding Dr. Walter as we speak.
Okay.
Good.
Hey.
How are you?
Good.
Good. I realized that my I have a 120-year-old house, and the Wi-Fi in our house is like questionable in basically every room.
Oh no.
So hence why I'm a couple minutes late. Hi, Ashley. How are you? Happy Sunday. Chelsea, I'm going to give people a few minutes to join
Sounds good.
before we start
Yeah,
chatting more. How's your day?
it's been good. It's been a lazy Sunday.
I know, hasn't it?
Yeah.
I made I've been in the soup mood recently,
Okay.
and I made a humongous pot of soup, which somewhat bums me out because then you're stuck eating it all week long.
Yeah.
Or you do what I do, which is basically freeze it and put it in your deep freezer and don't keep track of what's in the freezer. And now I've got like an entire deep freezer of soup.
Of soup.
And I
Yeah.
have no idea what's what.
Yeah. We're still eating on a crock pot of chili from last week.
Yeah, I know.
Yeah.
It's I love soup season. It's my favorite season. But you eat it over. Oh, and there's only two people at your house for the most part.
Yeah.
So it's at
Yeah.
least my kids like will devour. They eat more than both my husband and I combined.
Really?
Yeah, they really do. They really do.
Yeah.
And they love soup. Um,
That's
yeah. Well, I will. There's a handful of people joining, so I just want to give people a few minutes to join.
yeah.
I'll kind of talk about Anchor for a second before you talk about you.
Sounds good.
So for all of our new followers, which we have so many, welcome and thank you so much for following along. This has been quite a journey, but Anchor was started as a place to give people hope. It's an integrative healthcare collaborative that brings together like-minded health and wellness providers into the same space to provide highly effective, highly efficient, client-centered care. Um, it sounds like my 60-second elevator talk, and it is just that because it's not really any more complicated. I think we've all experienced what it's like to get into a system of healthcare and not be able to get out, or not be able to get out of it what we want. And so Anchor was started as a way to give people control over their own healthcare and empower people to to find relief and ultimately to find hope. Anchor is the international symbol of hope. And I think a lot of people feel hopeless when they're dealing with chronic pain, when they're dealing with diabetes, when they're dealing with weight issues, when they can't sleep, when they're miserable at work, and they're not accomplishing goals. And so the idea is to help bring people awareness that there's opportunities to feel better, do better, as well as that they have control over it, that we're just part of their team. So that said, I found Dr. Walter on the World Wide Web, and
Yeah.
I'm so grateful for it. And so it's interesting. 2020 is a weird time for, I guess, entrepreneurs, but specifically in healthcare. Google has always been the source of information. And now there's so many providers out there sharing information. And so I found Chelsea on Facebook, and I was just so impressed with the content that she was putting out, and her perspective on physical therapy. And more importantly, that it wasn't all like glitz and glamour, which is what I think a lot of people, especially right now in physical therapy, there's always like buzzwords, and I just loved how much of a purist what Chelsea was doing. And so we stalked her, and then we've had a couple weeks to get to know each other and share each other's goals and objectives with our profession. And so I'm just so excited to have you as part of our team. I think you're going to bring a really cool dynamic to our practice in some of your specialties that I want you to talk about in just a second. So why don't you tell us about yourself, kind of how you fell into physical therapy, where you studied, all that jazz.
Yeah, so I've been a PT for a little over 6 years now. I went to St. Louis University, where their program is you get in as a freshman. As long as you meet the prereqs and all that fun stuff, you get into PT school. And so it's 6 years straight through. So it basically cuts out a year of undergrad, essentially. So you still have the 3 years of PT school, and that senior year is a little extra grad school instead of undergrad. So yeah, I did that for 6 years, and then I originally thought I wanted to do a more neuro-based treatment. So I took a job at a rehab hospital in Las Vegas. So that was my first PT job, was working at a rehab hospital out there, and then came back to the Cincinnati area. I grew up in this area later on, and then so that I've been here back home for 5 years working in an outpatient office, and then decided that 2020 was a good idea to leave my full-time outpatient orthopedic job, and I'm starting my own practice, and that was how Sarah found me, and now I'm here.
Isn't that funny? There's definitely a couple different types of people, but the people willing to take risks during, a pandemic. And but back to your neuro experience, because that's how I started too. All of my clinical internships were neuro focused. My very first job was 50-50 ortho neuro. And I feel like that contributes so much today to my practice in general orthopedics, specifically in spine. But more importantly, even with those with chronic pain, do you feel like you have the same experience?
Yeah, like I said, I originally wanted to do the neuro side of it. I liked like the spinal cord injury and that sort of thing, but then I found that working, you only saw a handful of those. It was a lot of just like debility and people not taking care of themselves. I didn't get to see as much neuro as what I would have liked to. But I did have a lot of clinical experience with chronic pain too. So
yeah. I think my background in chronic pain probably started with dealing with people with spinal cord injuries and stroke, because they have so much pain, and recognizing all of the different organic causes of pain. So especially after suffering a neurologic injury, I think what's interesting, and especially for those people kind of listening and tuning in with us, is that traditional medicine, so medical school, there is a 4-hour lecture on pain for medical doctors, and that's it. So
that's crazy.
Yeah, right. So they understand, they learn nociceptive pain.
Right.
Pain that arises, from nociceptors, these free nerve endings in our skin and soft tissue, and that's the extent of it. And so I think it's a really interesting thing to mention, because physical therapy, which we're going to talk about, physical therapy in 2020 and kind of what it looks like. But, I think physical therapists have such an opportunity to capitalize on helping people with pain that's not measurable on, objective tests. When somebody doesn't show up with a fracture or a herniated disc or a torn muscle, at that point, doctors are like, yeah, sorry, for the most part, don't know what it is. Where we have such interesting skill. And I think especially those of us who have worked in the neurologic population, who have seen, what happens with pain because of spasticity or pain because of an actual cord injury. So anyway, so then after you worked in neuro, you came back to Cincinnati. When did you start to peruse through McKenzie and that specialty?
Yeah, so the McKenzie, I was introduced to that when I was still in school. So my last clinical rotation was in Chicago, and I was working with a bunch of therapists there that were all McKenzie certified. So there's 2 levels of McKenzie certification. So everybody in that clinic had one or the other level. So I was introduced to it at that last clinical rotation, and that was what I used for treating spinal issues up until that point. But I didn't I'd taken a couple of the courses on my own, but then I did decide to go ahead and do the residency program that they offered. So PTs you don't have to do a residency, you don't have to get a specialization, but that is what I think a lot of people are doing these days too. So the McKenzie Institute started an orthopedic and McKenzie certification residency. So I got the board certified in orthopedics as well as the McKenzie certification through that program.
And will you talk about like the McKenzie model and what makes it different?
Yeah. So the McKenzie method is very, it's mechanical. So the other name for it is mechanical diagnosis and therapy. It's just more colloquially known as McKenzie. It was started by a guy named Robin McKenzie. So it's a process. So it's figuring out how a person's pain or symptoms behave just with their everyday activities, and then putting them through a very specific movement assessment to see how various positions and activities impact their symptoms and how it changes it. And then based on those findings, giving them a very specific program to work on independently.
Okay. And so for a patient, kind of what does that look like?
Yeah, so it's sometimes people think of it as a little oversimplified because I'm giving them just one thing to do to start out with. So I'm not sending them home with 5, 6, 7 different exercises day one. It's usually, here's one thing to try out over the next 24, 48 hours and see what happens. And that's been my philosophy with it too, is that when you give somebody too much, especially to start out with, and they come back and they might be better, they might be worse, but you don't know what that is if you've changed too much.
Yeah.
Yeah.
So you mentioned this. So physical therapy, again, for those of you kind of tuning in that maybe aren't PTs, I don't know where it stands given that we're here live in 2020, but the APTA, the American Physical Therapy Association, back in the early 2000s, or maybe even like mid to 2005 or so, came up with this goal for 2020 for physical therapists to be completely autonomous. And with that goal, they also are trying to direct PTs into more specialized care. So the idea being that we come out of PT school as generalists, just like physicians, and then you choose a way to go from there into a specialty practice. Chelsea has pursued the orthopedic certified specialist. There's cardiopulmonary, there's pediatrics, there's geriatrics. Where I think that physical therapy is missing the mark with this, in my own personal opinion, is that these residency programs require a therapist to usually a couple of years, at least 1 year. Some of them I think are a bit longer. But you're working and learning simultaneously for a year after graduating or whenever you choose to do it. And you're usually working at a very discounted rate, which is fine when you're a physician and your discounted rate is, $100,000 or a little more. But as a physical therapist, when your discount is, $30,000 or $35,000 or $40,000, and then you graduate and you don't make more money. Whereas as a physician, you finish a residency and that sets you up to be, to make more money. And so unfortunately, just the reimbursement, and this all kind of leads into what we're going to talk about here in a minute, but the reimbursement rates for physical therapists don't go up based on your credentials or your experience. So, a PT who graduated yesterday is going to charge and be reimbursed the same amount as us today, with all of our extra specialties and all of our time and, and all of our skills. So, unfortunately, I think the people who are trying to progress our field have great intentions, but insurance right now sort of dictates, it's a limiting factor for PTs to advance their knowledge because there's no incentive. Do you have, so my class graduating from University of Miami, I think about 50% of our class went into a residency directly at a PT school. And I can't think of maybe more than 4 or 5 that actually finished it.
Okay. Yeah.
Did you have that same experience?
I don't think it was as high. We had a large PT class. I don't know that there was this high number of people that went into it directly after. I know there were a handful, but don't think ever, it was definitely not 50%.
Yeah.
I think a few people did it kind of like where I did, where it was a few years after graduating. But
Okay.
and as far as I know, the people that did start it did finish them.
Yeah.
But there wasn't a lot of us.
Yeah. So, I think it's just interesting because I think this is a good segue into, what we approach this topic on is like, why would you, in the middle of a pandemic, when employment is at its peak, unemployment is at its peak in this country, quit your job at a place where you were making probably a fairly decent salary with guaranteed hours, guaranteed patients, so why don't you share, a little bit about why you chose to make that decision, and then I'll share mine.
Right. Yeah. Well, and like I was never completely furloughed. Like our hours were cut, but I still had a job. Like I know some PTs right now don't have a job because of cutbacks because of COVID, but I still decided that they made a lot of changes during that time, and changes that were happening even before the pandemic, just with shortening the amount of time that we could spend with patients because the documentation requirements were so heavy, because you have to have that documentation in order to be reimbursed by insurance. So you spend all this time treating people, but your face is in a computer, or you're encouraged to pass them off to a PTA or a tech. I've been fortunate that a lot of my jobs I've not had to pass off to like a tech, but you're not getting that skilled care and that attention of a PT like you should be. And then just the expectation that I would be there for more hours with no change in pay, and it was not worth it for me. Yeah.
So I think for me, it came down to so much of my training being one-on-one with clients. Everything we were taught was, we have the opportunity to gather a lot of information about somebody. And I think this goes back to the mission of the APTA by 2020 for us to be autonomous practitioners. And I think that was the purpose of the doctorate, is to train us to be skilled enough to recognize red flags, recognize referred pain, recognize scary things. And when you are forced to spend 5 minutes of quality time with somebody, because, and where I was working, that was insurance, I learned a ton. I worked with a really great therapist.
Oh, yeah.
But in order to keep the doors open, we had to see 4 or 5 patients in an hour. And with that, I was max getting 10 minutes hands-on with somebody. And who knows what could have been missed in that time that I was passing them to an aide, or that I was giving them an exercise from across the room, or that I was walking away from them. And I just started to question why I spent 150 grand on school to spend 5 minutes max with somebody. And to mostly be just giving exercises, which, don't get me wrong, I believe in the power of movement, obviously, but I felt like, the exercises you could give somebody safely to then walk away from was so trivial. Like it felt like I felt like a glorified, I wouldn't even say a personal trainer, because I think personal trainers get a lot more time.
Oh, yeah.
And with their clients. So, I felt like a gym teacher, not to hate on gym teachers, they serve their purpose, but not in rehab. And so that, and then, and I think this is sort of a dirty secret in the rehab world, but while we as benevolent providers of healthcare really try and provide a service that we think is the best for the client, we also have in the back of the mind what that service pays. And especially as a business owner, it's a sad day when Easton pays more than manual therapy, which is true. And so sad. And for those of you watching and paying attention, electrical stimulation is useful for the moment that it's on you. And beyond that, it serves the purpose to prep tissue, I presume. But I haven't used electrical stimulation in 7 years. I haven't used ultrasound.
I have either.
Yeah. I haven't used, cool laser. I haven't used traction, mechanical traction. I mean, there's just so many gimmicks in a clinic that afford us an opportunity to walk away. Do you agree? I mean, it's like, there's a handful of times that I can think of in the last 7 years where I wish I had access to those modalities for like a moment.
Yeah. I haven't touched them in years.
No. Yeah. So anyway, I think it's interesting that Chelsea decided to quit her job in the middle of probably the most chaotic year that any of us have ever experienced to date. And I think it speaks highly to the fact that PTs are burning out at like an incredibly rapid rate. I think I told you, Chelsea, that like I graduated with 47 other therapists. Mm-hmm. And I can think of like maybe 10% that aren't practicing today. Yeah. And we're almost 10 years out of school. Yeah. And so I think that's something else for therapists for customers and consumers of physical therapy services to consider, is that insurance is it's literally degrading our profession. Mm-hmm. What conversations have you had with patients thus far in your experience since leaving your last job about, the difference about your delivery of care versus what it was before?
Yeah. Well, what we've alluded to already, we have time with them. We get to spend that full hour of time where we're listening to them, which is a huge piece of it too, is people need to be listened to. So when they get to come in and actually tell you what's happening versus, hey, I have 5 minutes, give me the lowdown of it, that makes a whole difference too. Right. And people have been really receptive to it too, because they especially those that have experienced that traditional PT and they haven't had the results that they wanted, and then here's somebody who can come in and help you in that hour or whatever time that is, and actually get results because you're getting paid attention to.
Right. Yeah, it's true. It's always remarkable when people tell me all the time, I didn't know this was physical therapy. Mm-hmm. Which I think is just like the funniest. Yeah. Because I don't have to I didn't go to Jupiter to learn some specialty skill. Right. I'm not doing anything that anybody else hasn't learned. I don't have, any super special knowledge aside from, what we've all been taught, but it's the application, and we just have time to apply our skill. I think the other thing that people don't realize that physical therapy can do is that we're preventative practitioners. Mm-hmm. So, it's not just wait until you get injured. And it's funny, the clients that I've worked with for, I've got some clients that I've known for 10 years since I first started practicing. Yeah. And they now have learned to shoot me a text message if they're worried. Right? Yeah. I did this. I just got one right before we got on here. Why does my neck get so aggravated every time I exercise? Right. And and we talked through it. And it's great that she's thinking that way. She's not hurt. It's not painful. It's not debilitating. It's not stopping her from doing anything, but she's paying attention. Right. Which is what's so cool. What does your, give us an example of one of your favorite cases you've had since you started?
Since I've started on my own.
Mm-hmm.
I have somebody right now that's just, she has a lot of other health issues going on, and she's fairly young. So, she wants to be more active, and that was something that she really wasn't able to do because of an old ankle injury that she'd had PT before and it didn't work. Right. Mm-hmm. So she's like, it was her husband basically got in touch with me and was like, hey, I think you could help my wife. And so then now that we're fixing the ankle injury, now we can actually start to work on more of that overall health and get her more active again. And she needs kind of that attention of somebody that has more of a medical background than just a personal trainer.
Right, right.
Yeah.
One of my favorite stories about a patient that I've seen over the years is the wife of a patient, and he was like, he contacted me and was just like, my wife every year has kidney stones. Every year she gets a kidney stone. Every year she has to have surgery. It knocks her out for a period of time. She's got these, health goals that she wants to achieve, and she just can't achieve them because every time she gets going, she gets this kidney stone. And he's like, can you just talk to her? Which is not a typical referral for us, right?
Right.
But I'm like, sure, yeah, why not? I don't see why I couldn't do that. And so she came in, we did an evaluation. Looking at her evaluation, she had been on, this woman was diabetic, and she had been on these massive doses of calcium and chondroitin. Massive doses.
Yeah.
And nephrologist never called it out. Endocrinologist never called it out. General practitioner never paid attention. Well, no wonder this woman was getting kidney stones.
Yeah.
So I sent her back to the nephrologist, and I called the nephrologist and I said, I don't know if she needs to be on this much medication. And he was like, oh my gosh, absolutely not. She had not had a kidney stone ever since.
Wow. That's awesome.
Like, it doesn't take a rocket scientist, but somebody needed to spend time with her and reconcile her drugs.
Right.
And that's not, we are skilled in that. I think people don't realize that PTs have just as much doctors of physical therapy have just as much pharmacology background as general practitioners. Now, when they get into their specialties, they get way more on the drugs that they see in their specialty. But general practice, obviously, in internal medicine, they're prescribing, so they're way more knowledgeable about the drug. But we at our elementary level get just as much training, off the job as they do. So I thought that's always one of my favorite cases about how dynamic our job is.
Yeah.
Because we can go from a case like that to what I think most people think of as PT, like rehabbing an ACL repair, or working with somebody after they've had open heart surgery. It's just so dynamic, and I think people don't really quite recognize it. But I think what's really cool about what you're doing, and I think what we're going to be doing together, is that I think we all share this similar belief that people don't have to live in pain.
Yeah.
And that people have the authority within themselves to get out of pain. They just need the tools to get there, and that's what our job is. And I think you think very similarly to myself and to some of our other therapists, which is, we are not lifetime providers, like I think some medical providers can be, and that's not, in medicine, we are trained to do the least amount of intervention for the most amount of output, right? Where do you see some of the advantages of PT going forward, beyond 2020? Do you see our profession being radically different? How do you see it changing?
I don't know that I see it radically changing. I just think that we need to get our word out there of what it is that we can do for people. I think, like you said before, that people think of PT as after surgery or after an acute injury, but not in the whole capacity that we can treat people. I want to be that first step when somebody has some sort of, even if it's just a minor issue. I don't want people to have to go to a physician first. I want them to be able to just, hey, even just call me, text me.
Yeah.
Where is that going? And I think that there's a lot of work to get that word out there.
Yeah. It's interesting. So when I started practicing in this type of setting about 7 years ago, I think I'm losing track of time. there used to be a lot of questions about, well, why would I pay out of pocket? And so I used to do the math equation a lot. And again, for those of you, watching and listening, I'll do that math equation for you. So most of the time, a physical therapy evaluation in an insurance-based practice is, between $250 and $350, unless it's a practice that's attached to a hospital. That evaluation is upwards of $550 to $650. So if you are somebody who has a coinsurance, a 20% coinsurance, you're going to pay 20% of that, and you'll be billed within 30 days. So if you have a $650 evaluation, you're going to be paying $130 for that evaluation at a hospital-based outpatient practice or inpatient. If you have a deductible, you're going to be paying all of that until you meet your deductible, and then your coinsurance and your copay.
Right. So
for most people today, their copays are $50. So you're paying that no matter what. You're paying your 20% coinsurance, so that $130. So now you're at $150 for your evaluation at an insurance-based practice. If you've already met your deductible. So you're paying $150 for somebody to see you for, maybe 30 minutes, right, maybe at your first appointment, maybe, right, if you're lucky. And then from there on out, you're charged, a follow-up is usually in a traditional non-hospital based practice, I think 150 to 250. And then in a hospital, it's more like 350 to 450. So again, apply that same equation: 20% of your for your coinsurance, your $50 to $75 copay if you've met your deductible, and if not, you're paying for all of it. Mm-hmm. So just the mere fact that the bill comes 30 days later, and I've heard people when they get those bills and they're like, holy, right, like, right, I just got $1,000, $1,500, $2,000 bill, and the physical therapist never touched me. Right. Like, I'm sorry. Like, I hate that for you, but yeah, that's traditional medicine. That's traditional PT, because we are inundated with patients, and because we have to pay the bill. I mean, you cannot, just these traditional practices can't afford to pay a physical therapist salary, a billing manager's salary, an office administrator's salary, rent, and overhead at, the rate that we get reimbursed, which I always tell people this, but the average rate that United Healthcare reimbursed in the city of Cincinnati, at least this was true a few years back, was $44. So you could see a patient for 5 minutes or 5 hours, and United Healthcare was paying $44. Now, whether or not that's still the case, I don't know. But $44. I mean, most PT's hourly rate is 33 to 43 or somewhere in there. PTs who are salaried. So you're talking about trying to operate and have a margin of $11. It's impossible. And I just don't think people understand that. And so I'm glad we're talking about it. While it seems quite frank and honest, I think people deserve to know, what they're paying for. Mm-hmm. And so when you look at our care, on average, we see people with acute cases 4 to 6 times. And so you're looking at about $600 for a plan of care. $600. It's a little different. Yeah. Right. Especially for care where you only have to come 1 time a week. So that's the other thing people don't think about. In a traditional practice, you're going to PT 2 or 3 times a week sometimes. Mm-hmm. Like, who can afford to take that much time away from work or away from their kids, mm-hmm, to go and have somebody tell them how to do short arc quads across the room?
Yeah. Yeah, so, and you're encouraged to get people to come 2-3 times a week.
Exactly. Again, right, it's just another sort of dirty secret of PT, traditional based PT. You're encouraged to have clients come multiple times a week. You're encouraged to provide care that, and that's profitable, right, quite frankly. And, I hate to say that out loud, but it's true. I mean, I've run a practice before, or helped run a practice before. And, you do take advantage of opportunities to make more money when you're trying to run a practice. I think the other thing that's interesting is that I think consumers of physical therapy think physical therapists make a ton of money.
Yeah. I
I
think so too.
Yeah, I remember thinking that I was going to make a ton of money.
Oh yeah.
When I was in
Yeah.
PT school. But that money did seem like a lot when I was 18 years old. It doesn't seem like a lot when I'm paying off my student debt.
Yeah.
And so I think people also think that physical therapy practices are super lucrative, and they're just not. I don't think medicine anymore is that lucrative, but definitely not physical therapy today. Do you think that it's appropriate for brand new grads to go directly into cash-based practices?
If they have the right mentorship there, but I think that you need to have and work with people, and you almost need to see what it is in an insurance-based world, because it gives you an appreciation for what you would be doing too. Yeah. If the mentorship is there, I think it's a good thing, but I think you need to see what it is.
Absolutely. I think if you have mentorship, I think it's perfect. I think it's a great opportunity. I think you can, as a PT who wants to build a life for themselves, I think going directly into it, but I would never advise going into it by yourself.
No way. Because I think about how I was coming directly out of PT school, and I feel like I knew nothing at that point.
No.
I couldn't imagine being on my own at that time.
No.
Yeah.
I always use this example of a patient I had who had hallux rigidus, and she was a runner. She was middle-aged and had just gotten into running, and had been using running to lose weight, and had just been gaining all this confidence. And but she came in with hallux rigidus, and I'm like, you have to stop running. And she was just like, this was literally like one of my first patients, and she was like, absolutely not, I cannot. And I just I looked to my mentor at the time, and I'm like, I don't know what, can she do this without stopping running? And, he had been practicing for 10 plus years, and he was like, yeah, absolutely. And so thank goodness that I had that guidance. And I will say a million things about the group of mentors that I worked with, both through clinicals, but definitely my first few years practicing, completely influenced my ability to help people today. Right. And it's like going off, and even if you go into a traditional practice, but being the only PT, it's the same thing. You have to go and learn with other people.
Yeah.
Yeah. Well, we have touched on so many topics. Is there anything else you want to kind of tell people about you, about your particular practice, really who you're best to help?
Yeah, I mean, like I said, the McKenzie stuff is very spine related. It does treat the other joints, but I do love the spine. I love people with the referred pain from the spine. I think I love those opportunities where people have tried everything else and they're not getting rid of it, or they have an isolated arm issue they've treated that source and it doesn't seem to be getting better, but if we can maybe look at the spine and fix it.
Yeah.
I think that's always a fun thing.
Yeah, I know. Those are my favorite cases too. I've seen a million people. Speaking of that, I've got to share a story with you tomorrow about somebody I met over the weekend who's been going to a chiropractor twice a week for the last 3 months and still feels the same.
Okay.
Not to hate on chiropractors. Chiropractors are awesome. They serve great purposes, but this particular one, I'm like, oh, this case, I can't believe this case. Anyway, well, it's been so fun chatting. I encourage anybody to reach out to you with questions. I think that, like I said earlier, Chelsea is bringing such a unique perspective to our team with the heavy spine background and the neuro background as well, and just ambitious as all get out and ready to just change our profession and change our future. So we're really thrilled to have you, and can't wait to do more of these, I'm sure. But do you want to tell people what your handle is on Instagram in case they want to talk to you?
Yep. It's at Dr. Chels, Dr.Chels DPT.
I know. I can never remember mine.
I know. I just recently changed it. So Yeah.
Well,
Yeah, I'm excited to be on board and be a part of Anchor.
good, good, good.
Yeah.
All right. Well, it's good chatting with you, and I'll let you go and I'll finish up and I'll see you tomorrow.
Yeah. All right.
All right. Bye.
Bye.
So, thank you guys for joining us. You just witnessed what we often talk about at the end of the day, which is, all of our personal grievances with our profession. And so I think what I'm hoping that you get out of it is, why we're doing what we're doing. Chelsea, myself, Dr. Chavez Klein, we've all seen the benefit of physical therapy. And we've all been sort of the victims of insurance. And that sounds so dramatic, but it's stifling. It completely impedes our ability to practice autonomously, and it ultimately lends us to providing less skilled care to the consumer, to you, the patient, you, the client. And so, you're seeing these cash-based PTs everywhere now because we've all just had enough of insurance telling us what we can and cannot do for a patient. And I think, at first, maybe the financial obligation sounds a little scary, but when you really sit down and do the math like we did a little earlier, I think you realize that it's just not nearly as expensive as you may think, and especially when you're talking about your health. If there's anything more valuable than your health, I don't know what it is. So send us any questions. We are always happy and eager to answer any of your questions. There are no bad questions, and we hope to talk to you again soon. Thanks for joining us.